Blood Bank Guy Essentials 008.
So when you start adding all of this stuff up, how in the world can you say that this one red cell that you got was the cause of their death when probably 20,000 things occurred to the patient inside the hospital, and that patient is already sick?
Hi, welcome to Blood Bank Guy Essentials 008. This is Joe Chaffin. I am excited to share this episode with you today. Dr. Kevin Land from Blood Systems is my guest, and he and I are going to take on some interesting and widely held beliefs in transfusion medicine, and we're going to see if they're true or not. We're calling it Mythbusters. I'm very excited about it. I think it's going to be a lot of fun. I hope you'll enjoy it as well. I just wanted to let you know that last week's episode of the podcast, episode 007 with Dr. Minh-Ha Tran discussing massive transfusion, turned out to be the most downloaded episode, the most downloaded first week of any episode that I've had so far. Thank you so much for listening. Thank you so much for reading the blog. Several thousand of you read the blog post that I posted last week on RH terminology. So thank you so much for everything that you're doing, the listening, the reading, the feedback. I can't tell you how much it means to me. I hope it's useful to you. So are you ready? Here we go. Episode 008, Mythbusters. Okay, welcome to the Blood Bank Guy Essentials podcast. Today's guest is a good friend of mine. Dr. Kevin Land is here from Blood Systems. Kevin, welcome to the podcast.
Hey, thanks, Joe. Glad to be here.
It is awesome to have you, my friend. I just want to let everyone know a little bit about you. Dr. Kevin Land is serves as the Senior Medical Director for Field Operations for Blood Systems. He is in charge of, he's the Chief Medical Officer for UBS Rocky Mountain and Dakotas region, which includes North and South Dakota and Wyoming. But that's not where his influence is limited to, that's for sure. Kevin is a clinical informaticist and a patient-oriented transfusion medicine doc, and he has spent much of his career on systems design and process improvements. He has, I don't even know where to begin with you, Kevin. There's so much that you've done, so much that you've contributed to in areas, including donor hemovigilance, among many, many other things. So Kevin and I have actually, in full disclosure, have overlapped in a couple of places where we've been, and we actually currently work together as part of his employment and my affiliation with Blood Systems. So Kevin, again, great to have you. I wanted to explore first with you something that I tend to explore with everybody that comes on this podcast, because I'm curious, what was it with your background? Obviously, you're a pathologist. You're also a clinical informaticist. What is it about blood banking that got you excited, and what is it that keeps you going there now?
Great question. So it starts a long time ago when I was a kid, and my dad actually worked at a blood center in Dallas in their research department. And as a 7 and 8 year old, I'd walk through the blood center there on the way to the elevators to go to his lab, and I would see all of these people donating blood, right? And this is the 70s we're talking about, right? Early 70s. You're hearing stuff about racism and inequality, and I'm a seven-year-old, so I'm hearing Walter Cronkite talk about it, but I don't really understand what it means,
right?
Because I didn't live in that kind of family.
Sure.
But here I am looking at these round tables where you have an elderly African American, a younger Asian woman, a middle-aged Latino woman, and then Caucasians, just all sitting around the table. They're holding one arm up for 15 minutes. Mm-hmm. And the only way they can have a snack, because if you remember back then, there's these big 5-pound jars of peanut butter and these big, huge containers of Ritz crackers.
Nice.
And restaurant style crafts of apple juice, orange juice, whatever. Mm-hmm. So if you wanted anything, somebody next to you had to help you either pour it or hold the Ritz cracker while you slather it with peanut butter. So
that's awesome.
One day I said, Dad, if everyone just donated blood, there wouldn't be any of this problem of people not trusting one another. Mm. So it sounds kind of campy, but that really kept through me all the way through college and medical school, and I was going to be a forensic pathologist or a PD hemonc doc, and my wife was pregnant, and I had a lot of patients dying on the PD hemonc floor. About the time we were making the decision of what's my career for fellowship and moving on.
Right.
And then I did a forensics rotation, and well, it's forensics, right? So there was a lot of stuff you don't want to talk about. And I said, I can't. And I just found out it was a baby girl, right? We'd just done the ultrasound. And I'm like, I can't bring my daughter ever to any of this. And so I said, you know what? I've always kind of liked blood banking. I had a great mentor in Hal Kaplan. And, I had an open fellowship position there. And I decided, you know what? Instead of helping people recover from their worst, transfusion can help people be their best for the day.
Nice.
And I decided that's where I want to spend my career.
That's awesome. Awesome. Well, I as I said, your contributions have been great. I know you're modest about them, but realistically, you've made an enormous impact in our field, and you continue to. So, I'm proud to be your friend. So, today, Dr. Land and I are going to have a fun conversation about a topic that I've heard him speak on before. It's such a great topic. We're doing Mythbusters today. Mythbusters, as you may know, was a television show that ran from 2003 through just earlier this year, 2016. A Discovery Channel, I think. I could be wrong about that, but I think it's Discovery. In the Mythbusters show, they would focus on, one or two popular beliefs, which may be true or may not be true. And they would take you through all kinds of fun stuff. They did things like toilet bombs and cell phones exploding gas stations and stuff like that. Basically with an eye towards just answering the question, could this really happen? Is this really true? And that's what we're going to talk about today, because there have been, over the years, a lot of beliefs that people may have, both clinicians and blood bankers, about things in transfusion medicine that may be true or may not be true. And we want to tackle a few of the more common ones. So Kevin, you ready to go? You ready to bust some myths?
Absolutely.
All right. So let's try we'll say statement number one, and you'll tell us whether it's a myth or not, that the biggest risk of transfusion or from transfusion is getting a viral disease. How do you respond to that one, my Mythbuster friend?
Well, I've given this talk a couple of times. The first time was actually in your neck of the woods a couple years ago, and I've given it to some residents, and I always ask them the question, and they said, well, it depends on what you mean. If it means the one that everyone's the most worried about versus the one that's going to kill you the quickest,
right, it's
a different answer. And I said, well, okay, well, then let's move on to the next section, because you so that's actually correct, right? Like you, I'm kind of a lifelong teacher. I love teaching all sorts of level residents, medical students, primary care docs out there. And over again, I've seen, just like you probably have, that when people talk about risk, they always focus on HIV, HCV, HBV, the hepatitis, the HIV. 'Cause those were so scary in the 70s and definitely in the 80s.
Right.
And when you ask doctors today, and you say, what's the residual risk? They say, maybe 1 in 1,000, 1 in 10,000. And I go, have you thought about what that means at your hospital? If it was 1 in 1,000 and you transfuse 20,000, that means you'd get 20 HIV cases a year.
Yeah, that probably they don't like that a lot, I'm guessing.
And they're like, well, we haven't had one ever. Oh, okay. Well, if you're doing 20,000 and it's been 10 years or 20 years, or I guess now 30 years, that's getting on the order of 1 in 600,000. So now we're getting kind of into the realm of where infectious disease risks are now, right? So, as you know, if you look at infectious disease testing that we do today, we do testing based on the antibody, based on the antigen, and based on the nucleic acid material of many of the different pathogens. We're trying to get the disease in different stages, early infection or chronic infection primarily. And for the big three, HIV, HCV, HPV, we're on the order of 1 in 1 in a million to 1 in 2 million. And to put that into perspective, I try to figure out, what's something that somebody might think about that would put you kind of in that same category. And I found that if you were to take a coin and flip it randomly 20 times in a row, and they all came up heads or they all came up tails, that's about the order of risk for those pathogens.
Yeah. Pretty small. But Kevin, let me interject for just a second. I think that even that may mislead people a little bit, because when you look at the statistics and you say, okay, well, 1 in a million or 1 in 2 million, but we're transfusing like 14 million units or however many million units in the United States a year, does that mean we're getting 14 to 15 HIV infections? And I think generally the answer to that is no, as far as we know, right? So it's not, even that doesn't necessarily accurately estimate the risk.
No, you're right. So the risks that we publish are based on population-based statistics, looking at incidences of new HIV or hepatitis, and looking at the window between infection to when we can reliably detect it. So for HIV, for example, there's about an 11, 12-day period, right, between when you're infected and you can reliably be detected as being HIV positive by samples. You might be detected earlier, but reliably, every time you go in, you'll be positive. It's about 11 days. So we try to calculate on that 11-day window, what's the residual risk?
Right.
But in practice, to your point, we only see one every, 5 to 8 or 9 years in the U.S., And we know from several publications that 50 to 70% of people who get a transfusion live, a year beyond their transfusion event. That's not related to their transfusion. It's more related to their underlying medical condition. So that by itself isn't enough to say, oh, well, so many people are dying because they're sick, right? The risk is so low because everyone else is too sick to be tested later. No, I think the reality is to your point, the realistic risk is on the order of 1 in tens to the million. But we state this just because we can count the numbers, and we can estimate using data that's been fairly well vetted by FDA and the industry.
Yep. So if we're not talking about as a very large risk from viral diseases, then what should we be worried about, Kevin? If the biggest risk isn't getting a viral disease, what are the other things that are potentially a problem?
Great question. So again, going back to what I said at first, probably most people are really worried about HIV, right? There's a lot of stigmata, unfortunately, still about having that disease. So they may be more concerned about it. But if you Google FDA and transfusion fatalities, you can see the list. It's public record of transfusion-related deaths. And I think they go back to 2008, and I think they have the 2014 data up recently. And you can see that the biggest reasons for death following a transfusion are trolley, are taco, hemolytic transfusion reactions, whether they're related to ABO or non-ABO red cell antigens, microbes that aren't viruses, the stuff in platelets, Staph aureus, Klebsiella pneumonia, Babesia, I think was in there as well.
Sure. Yep.
Or anaphylaxis. So these are the things that most likely will result in acute death, but are largely forgotten when we talk about transfusion risk.
Yes, for sure. And just for the trainees that are listening to us, TACO and TRALI, those are acronyms standing for transfusion-associated circulatory overload and transfusion-related acute lung injury. Just in case anybody missed that, sorry to to make sure everyone's aware of that, Kevin.
No, I think that's a good idea. And quite honestly, we don't know a lot about what those really mean, right? Mm-hmm. They're both lung associated injuries mm-hmm. following transfusion. One is volume overload predominantly, right? And mm-hmm. one is actually an acute lung injury as it relates to the transfusion. And unfortunately, which is beyond the scope of this talk, I guess, today or this conversation, mm-hmm. but it's hard sometimes to tease out which one is which.
Right.
But still, there's still a significant cause for morbidity and mortality in our patients.
So other things, you've mentioned the ones that are fatal. Obviously, there are also things that are not fatal. Do you want to mention those real quick before we move on? Because I think we've pretty much busted this one, Kevin, but...
Yeah, I think we've pretty much busted. I mean, obviously, you can have... Are you talking about like hemolytic... febrile non-hemolytic transfusion
things
reactions?
Like that, yeah.
Things like that. Yeah, I mean, there's definitely other things that can happen when you have a transfusion. It won't result in death, but would result in discomfort, right? Mm-hmm. If you get a fever, if you're getting a local or systemic allergic reaction, those can be uncomfortable.
Yep.
And we spend a lot more time signing out those cases. Mm-hmm. But one of the things that I think your audience should be aware of, that is, if you're not getting enough of those in your hospital, then you'll never get the other ones, right?
Yes.
That because you'll see 20, 30, 40 of those sort of reactions, febrile non-hemolytic transfusion reactions, before you'll see a trolley, right? Right. Tacos on the order of 1 in 100 mm-hmm. transfusions, probably a little higher if we were being honest. But if you're not getting any, and oftentimes, I'm sure you hear it as well, you hear hospitals say, "Oh, I haven't had a transfusion reaction in 5 years." Right. Well, that just tells me nobody's reporting anything.
Yeah, they say it as if it was a point of pride when it's a scary point, right? Don't brag about that one.
Nope.
Okay, so I think we can put that one to bed. The biggest risk from transfusion is getting a viral disease. We would call that one busted. Okay, so with that one out of the way, let's move on to the second one, Kevin, and that is this one. Blood donors that are type O negative are universal blood donors, and their blood is safe for everyone. That sounds reasonable. Come on, right?
Oh, absolutely. And quite honestly, as a everyday watcher of TV, that's what they tell you, right?
Yes, they do.
I mean, if you remember some of the Chicago Hopes and some of those, if you were O-neg and a resident in the ER, chances are you were being stuck right there and blood was going to be drained from you so they could save a patient's life.
Yes. Fresh whole blood, baby. Bring it on.
Fresh whole blood, baby. So, of course, for many emergency transfusions, right, whether that's due to trauma, due to GI problems, or an obstetrical patient who's bleeding, right? Those are the three most common areas for uncross-matched emergency release blood. O-negative blood works very well for those patients. But the reality is there's more on a red cell than just A, B, and H, right? There's no O on there for those of you residents that are taking your boards.
Yes.
What other things are on there? Asking you a question.
You're asking me a question. Boy, we've got all kinds. It's a sea of antigens on the surface of a red cell, Kevin. It's just a sea of other antigens.
A sea of antigens. Mm-hmm. So that's of course is true, but not all of them are the same, right? So some of them are worse than others. And so one of the things that I may have heard from you when I was taking my Osler course, that Kel and Kid kills, Duffy dies, Lutheran lives, and of course RH. Those are bad actors as well. So the ones that we're really worried about, the clinically significant ones, are RH, because about 80% of them result in developing an antibody. You've got Kel's, about 10%. You have little c and and E, which are about 3% risk of developing an antibody, and then Duffy and Kidd at less than 1%, but still important. So the point is that if you look, and I think there's an article from American Journal of Clinical Pathology from 2010 where it's just one hospital's experience. They found that if you looked at all their patients who received emergency released units, trauma units, ONEG trauma units, a significant number of them actually had alloantibodies, underlying alloantibodies. And it's kind of scary. I mean, I don't know if you've seen it, but it said that I think about 11% of the patients had some antibodies that weren't A or B related.
I can't remember the exact number, but it's in that ballpark.
Yeah, and so like 5 to 6% had a clinically significant antibody, the ones we listed. And they actually found that they had 15 antigen incompatible units transfused. Right? And 7 of those 15 had clinically significant antibodies. One of them had a hemolytic transfusion reaction. And so it's a lot more common than we care to think about. Fortunately, most hemolytic transfusion reactions don't necessarily result in death. But we're not here to avoid death. I mean, that's a pretty broad, right? That's a pretty safe thing. Well, I didn't kill anybody today.
Yay.
Yay. We try to do a little bit better than that, right? And best practices, right? If it's your mom, if it's your daughter, if it's your wife, or the reciprocal, you would want your clinical staff to avoid as much as possible developing the antibodies to begin with.
Right.
And number 2, exposing your loved one to a potentially incompatible unit. So clearly, even in the small retrospective study of like 1,000 units, there were 11%, 10 to 11% that had antibodies that would not have been protected against just by going with ONEG units.
So what does that practically mean for people that are working in hospitals, Kevin? I mean, I know that this is something that you're passionate about because I've heard you speak about it before, the intelligent use of O-negative blood. And it's maybe slightly off topic from what we're discussing here, but I think it's important for people to understand how can they help safeguard the O-negative supplies and only give it when it's appropriate?
Oh, thanks. What a leading question,
yeah,
right?
Baby. That's a softball right there.
Yeah, that's an underhanded pitch. I think I might be able to hit that. So, if I know you're aware, and I'm hoping most of your audience is aware that a few years ago, ABB put out a Choosing Wisely campaign, right? Where they went out and they said, okay, these are 5 questions that all patients should really discuss with their doctor, right? So the Choosing Wisely campaign is is a large campaign from the American Board of Internal Medicine Foundation that's really helps cut through some of the myths or some of the misperceptions in medicine, right? And the 5 that came about from ABB, one was don't transfuse more units than absolutely necessary. That makes sense, right? You should get all you need, none that you don't.
Right.
Don't transfuse red cells for iron deficiency without hemodynamic instability. Give them iron, give them EPO. Right. There's other things to give them, right? Don't routinely use blood products to reverse warfarin. Don't perform serial blood counts on clinically stable patients. That's a great way to give a transfusion later on, is to draw a whole bunch of blood the preceding days. I think there's a study that showed that in some ICU, CCU areas, up to a unit of blood was being collected every day just to test patients.
Incredible.
Yeah. And then the 5th one is the one that you're referring to, is don't transfuse ONEG blood except to ONEG patients and in emergencies for women of childbearing potential with unknown blood group. we have a crisis, right? In the world, it's not just the U.S. And it's sort of a good problem to be in the sense that we have a lot of great literature that's come out in the last 10, 15 years on understanding the Goldilocks principle of transfusion. Not too much, not too little, just right. And most institutions worldwide have noticed, as they've adopted these best practices, many people call it patient blood management, but it's really just adopting the best practices. They've seen a decline in transfusions on the order of 10, 15, 20, 30, up to 40%. The problem is that the decline in blood usage hasn't been across all blood types. So A and B and O pos have declined, but the rate of use of O negs has actually gone up. And recently published a study with Mark Yeaser and Neil Beckman from Australia. Mark is at ITXM in Pittsburgh, that looked at this across a couple of countries. And it's pretty staggering. And the scary part is, if people don't quit using O negs inefficiently, we're not going to have enough for those that actually need it.
Right. That's so important. And I mean, I talk to people all the time about this, and basically you really, unfortunately, we can't make O negative out of nothing. We can't fight population genetics, try as we might. There's only a limited number of O neg people out there, and it's got to be used intelligently.
Absolutely. And the reason why this is relevant to our conversation today is that one of the inefficient uses of O negs is using O negative units for adult males. And when you talk to these hospitals, usually the blood bank or the director or the lab supervisor, they are so worried, right, about giving an RH positive unit to an RH negative adult male who then comes back having had formed an anti-D, and then you give him another emergency OPOS unit, and then they have a hemolytic transfusion reaction and die. So I did a little napkin calculation of that, and I'm happy to supply you. It's 9 different steps, and I put references off to the side. So if anybody has a better reference, they can update it. Right? This isn't to prove a point. This is to make sure that we have the right information to make informed decisions. Right? And so if you start off with 41 million trauma patients per year on step 1, and you go through how many of them require red cells, how many of them survive, how many of them are Rh negative, how many of them are male, how many of them are over 18, because assuming that everyone less than 18 is probably getting Rh negative, O neg units, has another trauma after developing an antibody, and then has a hemolytic transfusion reaction, right? So we go from 41 million patients per year in the U.S. Down to 236 patients.
Tiny odds.
So that's much less than 1%, obviously.
Yep.
But yet we're okay giving quote-unquote unsafe blood 10 to 11% of the time for things that aren't ABO or RH.
Yeah. And, I actually, you mentioned Mark Yeaser. I had Mark on the podcast a while back, and he and I were discussing the, not quite that very issue, but something similar. And one of the things that he pointed out that I know you're very well aware of is that one of the that old 80% thing that people have said for decades about the risk of making an anti-D is probably in hospital, well, certainly in hospitalized patients, much lower, and probably in trauma patients even lower than that, right? Doesn't that even add more to your argument?
Yeah, we actually have had a nice debate over a pint of beer on what's the likely risk of developing an antibody in trauma patients. And don't know, but I think it's easier to say, though, from the AJCP paper, that people who present, right? Because we're already, a lot of places, especially west of the Mississippi, already give Rh positive, already give Rh negative units to everyone. More, I hate it's an oversimplification, but most of the hospitals east of the Mississippi give Rh positive units to males in trauma. A lot of hospitals west of the Mississippi either haven't or recently within the last few years have moved to that. So we kind of know what percentage of patients present. And that's on the order of 10 to 13%.
Got it. Yep. Okay. Well, we could go on about this one, Kevin. I know we could. It's a hot button for both you and I, and especially in our role as blood supplier, it's obviously very, very important. So, but we better leave this one alone. So, how would you categorize this one? That donors with O negative blood are universal blood donors, and their blood is safe for everyone.
Yeah, whenever you see always and everyone and no one, that's a pretty easy. So I would say that this is busted.
Busted. All right. But it's not quite as simple as the previous one being busted, right? There's more
Correct.
complexity to it. Okay, but we got to move on. So let us go to the next one. So here it is. And you mentioned one of the magical buzz phrases that's cruising around transfusion medicine world right now, and that is patient blood management. And one of the things that I think people may have gotten a misperception about is the following statement. Let me read it to you. Blood is bad. Transfusing leads to increased mortality. How would you like to take that one on?
Boldly.
I would expect nothing less from you.
So the thing is we know blood isn't entirely bad because we kind of need it to live.
Yeah, a little, yes.
A little bit, right? And we also know from Carson and others that if you look at the Jehovah's Witness literature, when you start getting below 5, mortality starts going up with maximum life-threatening levels reaching about 3 or less, and 0 hemoglobin is incompatible with life right now. Right. So we know that no blood is bad.
Yep.
But that's not really the point, is it? They're just saying blood is bad, that the transfused unit, there's maybe storage lesion, there's maybe some sort of manufacturing defect, blah, 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 that results in a unit that actually causes more harm than good. That started from well-meaning folks that looked at retrospective studies, right? Because that's the first thing you do usually when you're exploring, is looking at retrospective studies, that you say, okay, of all my patients, what happened to all my patients that received blood? Well, the problem with that question is there's a lot of associated risk in there that unless you correct for that, are you really measuring or evaluating death as a result of the transfusion, or are you just measuring a blood transfusion as a surrogate for the other risks?
Right.
And so sick patients are more likely to get blood. Older patients are more likely to get blood. Sick patients are more likely to have complications, right? People with 20 underlying diseases are more likely to have a bad outcome than somebody who just comes in with a simple, broken ankle or something like that. And unfortunately, many of the observational studies early on did not adjust for that. And so you started seeing reports in the literature that said blood transfusion is associated with increased mortality. Well, the problem is when we see associated, we think causation.
Causation, right.
But it should really be interpreted as prediction. It predicts. And, if you want me to, I have got a really good informatics story from Target that has nothing to do with blood banking or medicine, but shows what causality versus association really puts it in perspective that most people can go, oh, I get it.
Okay,
but,
it's a podcast. Bring it.
Okay.
Bring it, man.
Okay, so a few years ago, right, big data is a big deal. Everyone's trying to get everyone's data to figure out stuff about you. Google does it. Amazon does it. Anybody, any website you go to collects data about you, okay? Well, Target was trying to figure out, okay, what is the best category of customer I can get that that could be lifelong customers that would spend a lot of money here, right? These people are going to be spending money already, so they might as well spend it with Target. And they decided that young families, specifically pregnant moms, are a great group to target.
Okay.
No pun intended. So they have a registry, right? A Target new baby registry. And that they actually ask you, I think, when your expected due date is. So they started capturing, this was, 10 years ago or so, they started capturing all this data, and then they went back and said, okay, what were all the purchases they did leading up to the delivery, right? And could any of those predict if a woman was pregnant, if they weren't in our registry, if we didn't know they were pregnant? And they came up with 5 items that if were purchased in a certain order, but in general, these 5 purchases, they had like an 87% predictive rate of identifying a pregnant person. Could actually get pretty close to when the due date was within, a couple of weeks. That's pretty scary, isn't it?
That is scary.
And if you don't believe me, you can go Google it, because I think it was in Forbes or Harvard Business, because it's a pretty big case study.
Right.
So what they used to do is they would say, okay, we found somebody, right? And now we're going to send them some targeted email. Here's a brochure about all this baby stuff. And they would even be so bold early on as to say, congratulations on your new pregnancy. Here's some coupons to help you out. Well, the problem occurred because they sent it to a teenager, and it arrived at the house, and the father sees this thing saying, congratulations on your impending delivery. Here's some coupons.
Ouch.
Joe, you're a father, right?
Yeah. Yep.
So, like just about any good father would do, after he had a conniption fit, right? He calls Target and goes, "What in the world are you doing?
Yeah.
She's a teenager. You do not know what you're doing," and just berated him. I apologize, whatever. Well, apparently he was the only one in the house that didn't know that she was pregnant.
So often that happens that the dad is the last to know, right?
Right. So the 5 products did not cause her pregnancy. Do you know what the 5 products were? But they were predictive of her pregnancy.
Right. Okay.
So you know what those 5 products were?
Please tell me.
Large, like generic bags of like the puffy cotton balls.
Sure.
Multivitamins, large amounts of multivitamins. A bag that could be used as a diaper bag, but doesn't have to be a diaper bag.
Gotcha.
Big, nice, ultra soft towels like you would use to wrap a baby or swaddle a baby, and unscented lotion.
Those 5 things clearly cause pregnancy.
Now, even if the unscented lotion was KY jelly, that doesn't cause pregnancy.
We got to stop going down this pathway. Time out. Hold on. Danger. PG rated podcast, dude.
Well, we just got to the edge of PG. So anyway, that's my kind of silly but real life story of how observations, because that's all that it was a retrospective observational analysis, only gives you things that have an association or predictive ability. Right. It doesn't give you a causation. And so I'm sure you've reviewed articles through the years. I reviewed articles for several different journals. People are publishing these studies. And if you look in the studies, they haven't even normalized their data for severity of illness, for underlying or co-founding medical conditions, for the number of other blood products besides red cells that they might have gotten. Not all of them. I'm saying that some of them, right? They haven't looked at the volume of blood products that they got.
Right.
So when you start adding all of this stuff up, how in the world can you say that this one red cell that you got was the cause of their death when probably 20,000 things occurred to the patient inside the hospital, and that patient is already sick? So when you move to the newer data, the newer reports, they're randomized control trials where they try to control for all these confounders. And so far, every single one of them has said, no, really haven't seen a difference. Blood used appropriately, right, right, confers no extra risk. Now, I would argue, and I think you would too, that even though blood is safe, we've already talked about there being other risks.
Right.
Do you really want to roll dice with your patient if they really didn't need the unit?
Yeah. Right.
So one final thing, right, that if you look at the healthcare utilization product hiccup data from HHS, during the time where transfusions, and it's freely available, if you want to be an informatics nerd, you can go find it and download a lot of data, that during the time, a 10-year period of time, red cells doubled in usage to the point where it became the number one procedure performed at hospitals.
Right.
During that time, though, mortality across all of the big, like cardiac, pulmonary, things that you would think that would be at risk for dying, especially if they had a transfusion, the mortality for all of those severe diseases decreased. If you look at Nareg's study from Kaiser Permanente, it was in JAMA 2014, decreased red blood cell usage and mortality in hospitalized patients. He's got a great graph that showed that as the transfusion incidence went down, if you looked at controlled patients, he controlled for as many variables as they possibly could. Patients transfused, patient untransfused, but otherwise matched by age, severity of disease, blah, blah, blah. Their mortality decreases over time from 2009 to 2013. But you couldn't tell from one to the other which line was the transfused patient, which line was the non-transfused patient. They both had essentially the same mortality risk.
Right. Right. Yes, I've seen that, and in fact, we'll make sure that we put that reference on the show page for this episode, so people can make sure to check that out. We might even have a slide. We'll see about that. But so since we are running a little bit short on time, let's just bring it to the conclusion. So I think I know where you're going with this. If I say blood is bad, what would you say about that one?
Well, busted.
Busted. Yeah. No problem. Agreed. But I think you made some really good points about that, though, Kevin. And I think it's essential for the audience to remember that doesn't mean that either you or I is advocating just, oh well, it's totally cool, just do what you want. You still should transfuse intelligently and for proper indications. But in that setting, there is little evidence to suggest that we're doing anything other than helping people.
Correct. And if you've heard enough people talking about this, especially in the patient blood management world, there are some CMOs that would say, we started off on the blood is bad camp, and we think it swung too far over, where there were a couple of cases where patients nearly died in their hospitals because they were exsanguinating and people were worried about giving them blood.
Yeah. That is not the outcome you want. That is for sure. All right. Well, I think we have time for one more, Kevin. We'll have to do this one fairly quickly, but I love this one, so I want to make sure we hit it. And that is this: younger, fresher blood is better than older, stored blood.
It is a sexy statement, right? And it
Why,
goes.
thank you. I feel better about myself for having said it. Even though you wrote it, I feel better about myself for having said it. Sorry.
It kind of goes with this whole milk meme that we have, that when I go to the grocery store, I look for the gallon of milk that has the longest out date.
Right.
Right. And I grab the one in the back of the refrigerator, not in the front, Well, the problem is there's a little bit of disconnect between a unit of blood and a gallon of milk, right? A unit of blood comes from one donor who meets a pretty rigorous set of questions. Your audience should be very familiar with the FDA layers of safety.
Sure.
On testing and blah blah blah. We also know that milk is pulled together, whereas blood is from one unit. So what am I trying to get to? That it's a good meme in the sense that in general you want the freshest you can get. Mm-hmm. But the reality is if you use it correctly and you just grab it in a last first in first out, it works just fine for the vast majority of people in the U.S. just like blood does, right? And so we have some studies recently, right? Recess and ABLE and things like that have really shown us, because we're only looking at randomized control trials now, that if you look at blood that is released as standard issue, you go into a hospital, you ask for a unit of blood, it's going to have an average age on it, right? And that age is anywhere from 18 to 28 days in most institutions. The older that is does not necessarily reflect the fact that the blood center is giving you older units. It might, but it also could mean that your hospital is carrying too much blood on their shelf.
Right.
So I really think this is a really good indicator for both the blood center and the hospital work together to find a comfortable range, of the mean age of transfusion. The reason why I say that is the studies are showing that if you compare quote unquote fresh blood, 3-5 day old blood that's transfused with standard issue blood, there's no difference in morbidity and mortality in some pretty sophisticated, some pretty sick patients, right? ICU patients, cardiac patients, pediatric patients. The ones that you would think that would be at most risk of having an adverse event.
Absolutely.
The outstanding question, though, is that the absolute oldest blood, 41, 42 day, we don't know whether those units are as safe as the freshest unit. And the reality is that's a pretty complicated question. There's some pretty big ethical concerns. It's like giving everyone a glass of milk from milk that's expired today. Some of it will be spoiled. So I think it'd be hard to get that past an IRB.
Yeah.
I do want to say, though, that a lot of the things that we think about when we think about old blood versus new blood come from some recent studies that are looking at what we traditionally would think of as storage lesion effects, genomic effects, proteomic effects of blood as it ages over time. And I think we were talking about this before we started the podcast, but a recent study came out that looked at blood processing methods and how it affected microparticles. And some of these things that they looked at historically have been thought to be storage lesions, right? Microparticles, mtDNA, increases in the blood supernatant. And Canadian Blood Services and BSRI recently published in Vox Sanguinis that those things may have more to do with the processing methods, how you manufacture the blood, than actually how long the unit's been stored in a refrigerator before it's transfused. So do I think I think it's important to give units that are as fresh as reasonably possible. Yes. But for every unit that you give that's fresh, right? Mm-hmm. The FDA did an analysis of this. Every other unit you give is going to be older.
It's kind of automatic, right?
It's automatic. So if your average is 20 days and you're giving all your in utero patients 3-4 day old blood, right? Mm-hmm. Well, those 3 or 4 day old units aren't sitting on the shelf to keep your numbers down. Right. So then the average age for everyone else becomes 22, 23, 24, 25.
You got it. Yep.
So for every group of patient that you think it's so critical to give them the freshest blood, you make it older for everybody else.
Right.
So right. I think in general, it's important to consider if it's good for one patient group, it's probably good for all groups. I think in uteros, I'm okay with giving fresher units just because of the risk inherent. You don't want to give multiple transfusions. Mm-hmm. The second thing is we should probably understand a little bit more about what's causing the bad effect, if anything. And just because we can see a difference, I've published with Chris Silliman on proteomics of plasma and red cells, mm-hmm. and things go up, things go down over time, yes. mm-hmm. but we don't know what that means.
That's the problem. We're still guessing, and I think that you raise really good points about recess and ABLE and the studies that have been done, and I just want to reemphasize that to the audience. You will hear sometimes people saying that those studies have put everything to bed. I don't think they quite have, but they have answered the question pretty clearly of whether the way we're doing things routinely now is safe, and that answer is pretty much a resounding yes.
A resounding yes.
Yeah. Okay. All right. Well, Kevin, I think that we're going to have to close with that one. Maybe we can, you and I can get together another time and do another set of potential myths. But let's just go over real quickly what we've said. First, number one, the biggest risk from transfusion is getting a viral disease. We consider that one
busted.
Number two, donors with type O negative blood are universal blood donors, and their blood is safe for everyone.
Busted.
Thank you. Number three, blood is bad. Transfusing leads to increased mortality.
Busted.
Thank you. And finally, younger, fresher blood is better than older, stored blood.
Plausible.
Yes. Can't quite say busted on that one, right?
No, but if we were to say younger is better than standard issue, then that would be busted.
Agreed. All right, my friend, is there anything that we've missed that you want to bring up just in closing?
No, this has really been fun. Thank you for inviting me.
Hi, it's Joe with some closing thoughts. Thank you for hanging around. I know that was a long one. Kevin is so much fun to talk to, and I am pretty sure that I set a record for myself for the most times I've laughed during any interview so far. Anyway, the information I think was really useful, and again, I hope you enjoyed it. I will ask you one favor before I let you go. At some point the next time you're on your computer, if you don't mind, if you wouldn't mind going to iTunes and give this podcast a rating, like a star rating, a review, just a short review is all it takes, and subscribe to the podcast. What that does is it allows me to get the podcast in front of more people so that more people can benefit from it. In fact, it does make a difference. Those of you that have done that so far have put this podcast in the top 25 for the new and noteworthy section of the medicine and science podcasts on iTunes. Anyway, thank you so much for that. Again, I will let you go, but I want to leave you with one final closing thought as you go through your day. As always, I hope you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks so much for being here. We'll see you next time on the podcast.